Hello, everyone. Welcome to the Worldviews podcast. My name is Han-Sung Lee. I'm a political theorist and scholar of international relations. Today, we're going to talk about public health, especially in this very geopolitically sensitive moment when we have different views on how to do public health, how to control diseases. And for that purpose, I have no better guest than Shannon. She has worked at the CDC for many years. She was in Zimbabwe, she was in DC, she was also the Assistant Secretary General of the UN and the Deputy Executive Director of UNAIDS. So thank you so much for being here, Shannon.
Yeah, thank you for having me.
Great. Maybe we can start with this overarching question of where we are right now, right? It's been 4 or 5 years, depending on how we mark the end of COVID-19. Perhaps it hasn't even ended. In many parts of the world, we still struggle with the aftermaths of COVID-19. And of course, we have many other diseases, as you know, and many of them you worked on. How did we get here? And was there something distinctly problematic about this time, right? I remember SARS, I remember H1N1 when I was growing up. We also had some social distancing and remote schooling at that time, but I don't remember those public health crises being as divisive at home and abroad. I was in China, right, going through those 2 rounds, and I remember it used to unite us more than divide us. And on HIV, on other diseases, I also remember it was a cause of coalition building and collaboration. But why is COVID-19 so different, and why are we struggling so much with rebuilding our society afterwards?
Yeah, well, what a great question. I wish there was an easy answer, but I think it's probably a bunch of factors. I think, number one, we shouldn't forget how actually incredibly unique the COVID pandemic has been. At its scale, its global nature, truly it was the 100-year plague that had been predicted for some time, but we really hadn't seen since the early 1900s for flu. And so I think H1N1 and SARS each had some lessons learned, but they were much more narrow in terms of the countries or the peoples or the length of time at which they impacted than was COVID. And a lot of that will have to do with just the nature of the virus itself. A virus that was highly transmissible, highly deadly, especially at first, overwhelmed hospital systems all over the world, but also mutated at a rate that kept escaping, I guess you would say. So a little bit, much more severe, much more impactful. And, you know, some of the responses started out okay based on lessons learned from H1N1 and from SARS. But then I think it just didn't play out across the globe with public health trust and cohesiveness the way it could have. Yeah.
Right.
Yeah.
And you worked on a variety of diseases, right? You worked on TB, you worked on hepatitis, you worked on STD, HIV, AIDS. What are the transferable lessons and what are the repeated mistakes?
Oh, yeah. Well, you know, I think a couple of things. Maybe this is getting a little bit away from your first question, but I'll really be coming from a public health model, right? And I think there's a lot of debate these days about the politicization of public health. But I think we need to remember that public health has always been political. That's the public in public health. It's always been about people and communities and leadership and systems and decisions. What it hasn't always been is partisan in some of the stark ways we're seeing partisanship, particularly in the United States around public health right now. But it's always been political. So maybe put that there already. I think a second element that's really important is that has lessons learned, and we tried to expand on these lessons learned, but I don't think they were heard very well, is how decisions about public health interventions have to take into account society and rights and disparities and access and all these different things. And we have a lot of those lessons, done well and done poorly, right, from the HIV epidemic, for sure. I think in May of 2020, so just a few months into the real beginning of the pandemic, one of the products we put out from UNAIDS was how to have rights in an epidemic, lessons from the HIV response.
Right.
You know, because this was in the middle of shutdowns, lockdowns. Should we, shouldn't we? What should we be doing? What we should be restricting for school, for work, anything else?
Yeah.
And I think that sort of compilation of best practices, evidence, and lessons learned, you know, hit on a couple of really important points, which is you can have restrictions on people and their movements and their activities for a public health mission, right? In a moment where you need that. But to do that well and to have it be effective, there were some really important lessons we put out there. So if you're going to put restrictions in people, they should be evidence-based. They should be time-limited. They should be subject to review beyond the people making those restrictions. Yeah. So whether it's courts or other bodies. And they need to take into account those who are most vulnerable to be disproportionately impacted by those restrictions as well. And they have to make accommodations for that. Which, as you can imagine, could suggest even if we're going to have some shutdowns, we need to figure out what does that mean for food access, income access, gender-based violence at home, learning losses. You know, how long does that go on or not? How do you weigh those balances? How do you be transparent? How do you change those restrictions as the virus or the situations or the social conditions change to make sure you're not stuck in something that's damaging for the long term? And I think that didn't happen a whole lot, you know, and it wasn't for lack of warning.
Interesting. Yeah. That's really interesting to me for two reasons. When I'm wearing the international relations hat, I think about what you just said. It resonates a lot with how we understand interventions of other kinds, right? Policy interventions, or even sometimes military security interventions. How long is it going to last? Do you communicate clearly with the target audience when you are going to pull out and relax and adapt? And how do you deal with the fact that any intervention will have disproportionate effect on the population along the fault lines of existing socioeconomic disparities?
That's right.
And in the case of public health, you have people with underlying conditions and other problems, and they're going to, you know, receive it very differently. And then when I'm wearing the philosophy hat, I think about this rights-based versus, how do we put it, health-based or performance-based or outcome-based approaches. Many posit a tension between those two. Generally, we even think there is a rights-based approach versus development-based approach, right? In the larger sphere, like, do you focus on the rights first and then think that from the rights will emanate all the results you want? Or do you say, let's target the results we want, make sure we actually improve the material conditions, then maybe rights will come along, right? Those are not clear-cut, but there are debates, right? When we talk about Indian, Chinese development, when you are obsessed with certain categories of rights, perhaps you're not even getting to you know the outcome that you want. So I wonder, in this case, what do you think about that kind of the conceptual distinction? And since you worked in Zimbabwe, I'm always interested, and I never asked you this, but do you think also culture plays a role in the way we navigate between these different approaches, right? We want both rights and health. Does cultural norm come into our way, and if so, in what ways?
Oh, I mean, of course, cultural norm comes into the way too. But I want to back up just a little bit from there. And I think certainly from a public health perspective, I would argue that it's not such a clear divide, either or. That, in fact, not only should we be interrogating and looking for how do we get the public health outcomes, which is saving lives, reducing morbidity, having wellness, while doing it in a way that either minimally impacts or even elevates human rights. And it's important because in many aspects of public health, we can show that the medium and longer term outcomes can't be achieved in ways that are just suppressing lives. So it might feel immediately like there's a payoff by having an either or, but we know actually over time you don't get the cumulative impact on a lot of things. You know, I think one example that's also relevant to this, and it's a little bit tactical perhaps, but so for example, for health behaviors that require people to act differently, let's stop smoking, you know, or HIV prevention, any of these different things. Although immediate shock value of sort of fear-based or shame-based marketing or interventions can cause a lot of people to stop in their tracks, it rarely lasts. It rarely causes changed behaviors. And you will remember that a lot, I think, particularly in some of the countries that are most polarized over public health now, a lot of the messaging ended up becoming, at least the social messaging in communities, very shame-based and fear-based. Well, if you won't wear a mask, then you don't care about me. Or if you won't do this, then you're saying everybody should die. And honestly, that is a strategy we know doesn't pay off over time, and using the excuses like, oh, we're just focused on outcomes. It doesn't do it, right? It doesn't get you there. And in fact, it undercuts that very trust that you need to get there. Yeah. So I think, there are ways to do both. I do think it's important to keep our eyes on the prize in terms of the outcomes. Yeah. But I think if we want higher level and more sustainable outcomes, we actually have to bring rights, behavior, community, society, culture into the how, more so than the what even, right? The how and the who is helping to deliver and design these interventions versus just the what.
How interesting. Hearing your practice-based insights makes me think that perhaps a lot of the philosophical puzzles we have should really be contextualized in something like public health, because, well, when you teach Philosophy 101, the students will ask, right, how do you reconcile between a more categorical, content-based approach versus utilitarian approach, right? Yeah. The utilitarian would be like, I want results now.
No matter what.
No matter what, yeah. Right? But then you were saying if you introduce the dimension of time.
Yeah.
And effectiveness over time,
yeah.
I mean, not just cultural norms, but the idea of the ways of life, when you're trying to change people's ways of life based on scientific evidence, right? Whether it is social distancing or smoking, or nowadays, right, with larger scale migrations, when, let's say, an island nation gets overwhelmed by rising sea levels and migrates to another place, as social scientists, we're telling them to change ways of life.
Yeah.
That really, you need a lot of trust in there, right? Yeah. And the trust is built over time, and that chronology requires you to reconcile different approaches, and not just be rights obsessed or by outcome obsessed.
Yeah.
Right? That's super interesting to me. I also wonder, when you were working on these other diseases during something like the COVID-19 pandemic, did you feel that concerns with other diseases, whether it is underlying conditions of older populations, or if it is a non-COVID related disease like sexually transmitted diseases, do you feel that sometimes we relegate the other ones to the background, and there is this kind of hierarchy and ordering of public health crises, even though they really do compound on each other?
Well, I mean, of course, right? There's only so much bandwidth and attention in some ways, and I think particularly in a situation where in some countries clinical facilities were overwhelmed by death and illness due to COVID. And so they had to focus nearly all their resources on that acute event. But other places where perhaps they weren't overwhelmed with illness yet, but there were shutdowns and restrictions of movements that actually then made other routine health care for other conditions inaccessible, right? And you got to wonder, were there other ways to go about that, all right? But I think also, saw a lot of situations where we had better outcomes and actually some momentum for improvements on some elements of other diseases, even during COVID, which might surprise you.
What mechanisms?
Yeah, so a couple, I think 2 examples I can think of. One example is for HIV, but it holds for some other diseases as well. HIV, a chronic disease, you need medication every day for your entire life to keep it at bay. We've got great medications right now, highly accessible in nearly every country around the world. Still not where we need to be, but pretty darn good. And even normative guidelines from WHO, and normative guidelines are never at the front of the curve. They're a little bit slower, right? So they have to be really solid by the time it came normative guidelines, had suggested both to improve people's success with treatment, their long-term retention, to reduce the stress on the healthcare system, to reduce the amount of nurses and doctors you would need, things would happen like if you've been a patient, you've been on these medicines and you're doing well on them and they're your normal medicine. How about instead of having to come to the clinic every 2 weeks or 1 month to pick up your next drugs, maybe we should be giving out 6 months of drugs at a time. Now, some countries, this came from, some countries did it and did it very well and showed high levels of success. But prior to COVID, there were a lot of country systems that would not allow that still wouldn't allow what we called multi-month dispensing.
Right.
They wanted the patients to have to come into the clinic every month. There's a lot of reasons for that. But that's a lot of money, time, expense. Well, with COVID and clinics being shut down or overwhelmed, many countries then routinized multi-month dispensing. So we had clients all over the world, including countries that had been adamantly against this, suddenly getting 3 or 6 months of their medicines. Whew. Big problem is some of those countries now are taking that ability away now that COVID's gone.
Really? Okay.
But that was one sort of counterintuitive kind of thing, which also showed that you don't necessarily need to have just this all or nothing hierarchy.
Interesting.
Right?
Yeah.
I think the second element where maybe it was a bit of a missed opportunity, the networks of people living with HIV in countries around the world. For the HIV response, there's been a lot of strong focus on the idea of community-led organizations, community leaders, roles, a sort of nothing about us without us principle to HIV care and treatment and prevention. And that has been regularized in a lot of programs as community-led organizations being part of direct service delivery. Maybe they're the ones that deliver some of those medications. But also being at the policy tables for making decisions around health policy for their community and being in the accountability lane for community-led monitoring is what was promised being delivered. And that also has been great for trust, outcomes, effectiveness. So many of those networks that existed to play one of those three roles, we could activate in the early days of the COVID pandemic to say, well, what do people in your network say they need now most? Do they need information? Do they need soap and water? Do they need access to their routine health care or medications? Number one was usually access to their routine medications. So how do we figure that out? But what we didn't see get taken up by the COVID response on that is eventually many countries did use, let's say, existing community-led service providers from HIV to do COVID outreach and services. Most of them did not then invite those same leaders or organizations to either the decision-making table or to the accountability table. And so that's a hierarchy in a sense of sort of picking and choosing how, yeah.
That's very interesting. So you gave two examples. One is at the policy level, and the other one is more like at the grassroots level, right? That's really interesting. Do you see any change in terms of the momentum of medical research? Because there was a surge of interest in, of course, controversies over, but also a lot of investment into vaccination during COVID, and now there are some lingering questions on so how do those patterns of investment fare after the COVID-19 ends, quote unquote, but then do you overall see a trend toward more intense medical research, even if it means competitive, if it's more geopolitically competitive, right? China, I think, is now a major innovator in medical technology, actually exporting a lot to the U.S. in terms of pharmaceutical products. The U.S. claims that we want to be also supply chain secure when it comes to China's challenge in that domain. Should we feel optimistic about post-pandemic medical research, or is it just being more geopolitically contested?
Yeah. Oh, what a great question. Well, I'm a big believer in innovation, new technology, and discovery. So, everything we've learned. Actually, part of the reason we could respond to the COVID pandemic so quickly, even if it didn't feel like that, was based on a lot of discovery in science and basic science and immunology and viruses that had happened for the 1, 2, 3 decades before COVID. That's why we got the mRNA vaccine so fast. And then we learned a lot during the COVID pandemic as well. And so I am a true believer that innovation is critical. I think the second component of that, and then I'll get to the real component. Second component is, I think it also re-emphasized something that we knew but perhaps had not been taken as seriously as it needed to be, is to get innovation into products and access. You also need a much more diversified ability, not just to be a discoverer or innovator, but to apply that technology to produce it, to shape your own market, right? And so I think, looking at how few vaccines are being produced, let's say on the continent of Africa, even though that continent uses a high proportion of the global vaccine production, this was a good reminder that it's not just the discovery alone, it's the whole chain that should be coming into question. But I think on the third column for me, I would say, but it is at this very moment, and I hope this moment passes, if U.S. investments in biomedical research through NIH, through collaborations with pharma, are stuck at the cuts and the slashing and the stoppages that have been happening in the last, 9 months, that will have major impacts for the whole world, because I don't see any other countries leaning into stepping up at that scale. And I think the reality is money matters for discovery. And government money matters even more for conditions and items that you would say without government funding, there's a market failure for. There's not incentives for independent pharma to do the whole discovery on their own. So I am very worried right now at the reduced level of financial investment, the rhetoric around and actions around defunding some of the biggest sort of scientific innovators, including higher education institutions on this. So that should worry us all.
Again, in public health, I see the possibility of reconciling these false dichotomies and trade-offs, one of them being, well, either you have an industrial policy-driven mode of innovation, or you just somehow let the market be efficient and productive. You mentioned that it's absolutely important to have some kind of industrial momentum, and it's sometimes even important for government and government officials and scientists working with governments to come in and spell out different directions that we can go forward, right? And of course, you need a dynamic market mechanism to make sure that we have the best products. So in some ways, we should. I mean, it's not just the Chinese mode of innovation that there is industrial policy and there is government level, central government or local government, right? The market innovations. Maybe that's something we should all be doing, right? That's very interesting. The last question on the aftermath of the pandemic has to do with this geopolitical international order. We see that even in very normatively driven countries like Germany, Switzerland, elsewhere in Europe, within the highly legally integrated European Union, the first instinct, right, when at the outbreak of the pandemic was to close borders, secure PPE storages and warehouses, and the European states trade accusations of monopolizing PPEs because, right, in good times, of course, I can store all of my masks in your country, but when the pandemic hits, you close the border, I don't have masks. Do you think that COVID-19 has left us more united or more nation-state interest-oriented and sometimes even more realist and geopolitically sensitive about the self and other divide?
Interesting question. I would say I think there are a lot more people, including public health people who maybe don't always pay attention to some of these things, but I think the public more, that perhaps come out of the COVID pandemic with enough examples that are undeniable how in bad times we saw countries revert to nationalism, whether it's vaccine nationalism or PPE nationalism or things like that, that it's perhaps something that can't be ignored despite a, good times stated commitment to collaboration, seeing what actually happens into the scramble, I think is sort of undeniable, right? But I don't think that everyone accepts that as the way forward, right? So how do we potentially impact that? There's exploration going on, right? So WHO at the World Health Assembly this year, after, depending on how you count, 3 or 4 years of working on this from member states, passed a resolution on a pandemic treaty that opens the way for a lot of work this year that ideally will have the most important addendum of the treaty so that the treaty could actually be voted on and ratified next year at the World Health Assembly. That pandemic treaty is intended to potentially put a framework and agreements in place that will mitigate some of that nationalism that happened immediately, right? We can all have our opinions on how treaties aren't enforced, how powerful they are. There's certainly the philosophy of the pandemic treaty, not just the philosophy, but very clearly delineated is there's nothing in the pandemic treaty that would overtake national sovereignty, right? But that is, I think, an effort to be both realistic in realizing and recognizing what did not work, despite intentions to the otherwise, and trying to establish more formalized agreements in advance that could be a bit more protective when we encounter the next thing. But I think the second thing, I hope it's highlighted a bit, is supply chains, even without nationalism. But if transport or borders or other modes of exchange are interrupted, then you start to find out a lot more where your supply chain came from. And including in healthcare over a number of decades, this idea of efficiency, financial efficiency as being deduplication. You're going to have one center, one production, one site from which everything is exported, I think has been not just rewarded but encouraged in a lot of the business models, right? And believe it or not, we've had interruptions and real problems from that over the years, but they have been more undercover. So the one facility that makes the bulk of the IV fluids for hospitals across the United States has to shut down for some reason, and suddenly there's a shortage of IV fluids. Not sexy. Most people don't know if you're not in the hospital. That's been happening for a long time. I think COVID really showed that, in fact, efficiency as defined as consolidation only is incredibly fragile. And it does not provide a resiliency for the users of those products. And so I also hope that some of this momentum, which fortunately I think is incentivized by more countries or regions wanting to have facilities and capacities more along the whole, production chain, not just on the user supply chain. That motivation perhaps can also help us redefine this idea that consolidation and efficiency are the highest, value versus resiliency and sustainability. And having that requires a little bit of redundancy, right? So if one factory shuts down, there's a second option. So I'd like to see our business model and some of that change too.
That's how I feel about the Deutsche Bahn. The Germans, they take away the duplicated tracks, but then once you're stuck on one, you're done.
You're done.
So I guess maybe I can summarize this lesson as neither deduplication nor decoupling. Right? You don't want to cut all the ties, but you also don't want to rely on this assumption that somehow just by occupying one position along this long supply chain, it can be safe, right? Sometimes it's not just nationalism and intentional harm to you by another nation state, but it's just that when pandemics hit, we are all struggling, and
Yeah.
you cannot rely on outsourced capacities, right, at the first instance. Yeah, that's very interesting. We talked about vaccine nationalism, and I wanted to talk about the politics of vaccine, even within a nation. We see that in the U.S., and we know that this year, I think it was in August, a Georgia man came up to CDC and fired 180 shots, destroying 130 supposedly blast-proof windows to express his discontent with CDC's stances on vaccination. He thinks he got depression from that. But that's one violent instance of a larger phenomenon, which is, according to some surveys, American trust in not just the CDC, but science, abstractly understood by the American people who have a very complicated relationship with science in general. But our trust has gone down, I think, from 60% to 73%. That's very worrying, right? It's not just the contestation over scientific authority, epistemic interpretations, but science itself. But certainly whose knowledge counts, which experts should I listen to? Which narrative should I subscribe to? Can you say a little bit about this very, not just geopoliticization of supply chains and public health, but also the politicization of science itself in the U.S.?
Yeah. Well, I'll probably misquote, but reference, Dr. Tony Fauci has said a lot recently, when untruths become the norm, then we're all in trouble, right? And it is a problematic time for alternative facts, untruths, mis and disinformation. Certainly when it comes into the vaccine realm, it's been really problematic. I would also point out that anti-vaccine and vaccine hesitancy concerns have been expanding in the United States for sure since the 90s. And honestly, they had continued to increase even before COVID.
I see.
And clearly, the very subtle, soft, traditional public health approach of if we just give more information, then people will believe, was never going to do it. Particularly when there were concerted efforts to promote lack of trust in vaccines, right? And so I feel like that all just got escalated with all the controversies around COVID. But in the States, of course, that is, I think, having even a higher impact because of the partisan politicization that's happened around to it. So that for or against, who are you with, you have to believe who you're with, has just escalated what was already a problematic issue on vaccines and on science, right? The partisanship around it makes it feel even more polarized, and it is. But I see it in a bigger context than that, I think, which is not just a partisan context. I'd say it's more the misdisinformation and sort of social media and connectedness moment we're in right now that I think we don't have the tools to really address, right? So a couple of cultural moments where feelings and facts are looked at as equally important, sometimes feelings being more important than facts. So it's not just the lack of facts or the untruths. It is this juxtaposition of feelings versus facts and what matters more. I was talking to one of our colleagues, Dr. Sam Bradshaw, recently, who's an expert in mis and disinformation. And she was talking about, the algorithms on a lot of social media. They incentivize feelings. They incentivize where you get the clicks, the monetization, everything. The algorithms incentivize content that evokes feelings, not content that evokes knowledge. And I think that comes back around to the moment we're in, post-COVID, the subject of vaccines. Yes, the addition of polarization about science, but much more than that. What are the levers that are incentivized to promote mistrust, to disincentivize, knowledge or facts, but also at a political time where there is a lot of delegitimizing organizations and credibility, not just facts alone, right? So if every organization is delegitimized, trust has to do with that, but it's even more deep, I think. It's a structural issue, right? If we're delegitimizing institutions that are supposed to be expert and critical,
Right.
then that's just facilitating everything else, right?
Yeah. The American medical expertise, right? That community is facing challenges not just from the skeptics, right, on the streets, but also from the top leadership. So
Yeah.
you're kind of stuck in between and facing this crisis from all corners, right? All
Well, and from social
perspectives,
influencers.
right? From social influencers.
Right?
Yeah, you talked
Social
about that.
influencers who
Yeah.
are making a lot of money by being the
Yeah.
alternative to these other things, right?
Yeah, exactly.
Yeah.
And sometimes because DC is a very peculiar place.
Yeah.
We tend to, even like when I go into bars and restaurants, I hear very evidence-based policy discussions. That's just it's not very representative of the U.S., right? We're like when we go into when I drive from Boston to Western Massachusetts, or when we drive from Virginia to West Virginia, when we go into the South, when we go into the Midwest, I could present myself as an AU professor with a PhD, and I can say my colleague Shannon, she was trained at Stanford, Georgetown, Emory, Columbia. Just the invocation of credentials and knowledge accumulation, it may not do the trick of convincing people, right? Maybe sometimes the more we invoke those credentials, the more they choose not to trust us.
That's right.
How can we bridge this gap in epistemic trust? Yeah. Like, do you think there is something we can get started on, like, actionably speaking?
Yeah, this is hard, right? This is hard, and I think we're in a bit of unknown. And I think, traditionally, public health in terms of building trust has definitely doubled down on, the facts and communicating clearly and transparency and showing your work kind of thing. And I think all those things can be useful, but I think they don't get to the core on some of the things we need to do.
Yeah.
I would say from both the evidence, but also, a practice background too, one of the things we've lost and we need to double down on is I believe trust is built by doing work together at local communities that actually impact people. That's tangible. Hands-on partnerships and people working together. What does that mean? What does that look like? What's happening at community level for, groups of citizens, whether they are faith-based groups or associated with the local government or, networks of, local Democrat or political organizations, any sort of social community groups. To what extent are they members of any of those audiences routinely engaged in, so what's happening for community health in our community? If most of our community members are dying of high blood pressure, what are we doing about it? Things where you can potentially say, well, this year we're going to really focus on getting everybody screened for blood pressure and figuring out what it takes and figuring out how we disabuse people of their fears on this. Who knows?
Yeah.
Just one example. But we've done less and less of that for mainstream health over the years. I'm very sensitized to it from the HIV response because it's been part and parcel of how, especially in this country, but around the world, we've rolled out work. We have Ryan White planning councils that were funded by the federal government to bring community members together around all the policy decisions and funding decisions for HIV care and treatment at the local level. Building and making decisions together and getting updates together, that actually just changes. Don't always like each other, but you know what the credibility is, right?
Yeah.
And in fact, for public health, we've gotten further and further away from that. I, came up through a program at CDC that is the Epidemic Intelligence Service, which is the virus hunters, those who got deployed to investigate outbreaks. And the image of that service over the years has been the picture of a globe, but with a shoe that has a hole in it, like a sole of a shoe that has a hole in it. And it's a traditional term called shoe leather epidemiology. The idea of figuring out what disease is and how you intervene on it in an outbreak is about pounding the pavements. It's you're wearing out your shoes, that shoe leather, to go and talk to people and explore. And then you can have hypotheses and you can test them and evaluate and figure out what the problem was and find the solution.
Wow.
And, my very first day of work at CDC, in fact, I got deployed to rural Mississippi in August for a month to investigate an HIV outbreak in a rural area. And that's all we did. We talked to everybody for a month and did the science along with it, right? In recent years, some of our recent EIS officers have joked, but actually they haven't been joking at all. Many of them felt very profoundly that logo should be changed from a shoe leather, to a computer. Because all we do is sit in a computer and pound data, because that's all we need to do to figure out what the outbreak is. It's like, that's the problem. We need big data. We have better analytics. We have better ways to sort of diagnose and connect information across vast territories. But if we're not also still, as public health experts, particularly from community level, going out and talking to people, meeting people, exploring these ideas, sharing that information, then I don't think we'll ever get to building trust again.
Right. That's true democratic spirit, right? You need to actually go into the community and connect with them. And it's how I feel about social science, in some cases STEM science research as well. We sit behind the computer screen and we run regressions and we come up with sometimes very simplified conclusions. We publish them, thinking that we've got it. Sometimes it's just not even reflective of the reality. Sometimes it is reflective of the reality. There are genuine insights, but then because the formation of that knowledge doesn't include the communities, then the communities, when they read the conclusions and the insights, they don't feel that they're part of the story. And so I guess your work on the HIV also tells us that inclusivity and representation is very important, not for the formal ritualistic aspect, which is also very important, right? But because maybe we will have alternative ways of thinking about a certain phenomenon if we listen to those.
Yeah, well, I mean, maybe we'll ask different questions, actually.
Yeah, exactly. Sometimes
much less have people ready for the answers.
Questions.
Yeah.
Exactly.
Yeah.
You mentioned the WTO, WHO. You mentioned the WHO, and of course, it makes me think that we are having this very complicated relationship with WHO and with the UN system in general. Can you comment a little bit on the US retreat from the WHO? And also about your experience at the UN, right? We have a lot of criticisms level at the UN. We don't have something parallel to it or to replace it, at least in the here and now. What should we do with the UN? Is it reformable? If so, how do you reform it? If it's not reformable, what can we come up with?
So much, right? So much we could talk about here. So, I mean, first of all, I would say I believe in the WHO, which does not mean I think it's perfect. I do find the full withdrawal, especially the funding with very little notice, will likely cause lives, and that makes me very, very sad. And also, I can say, honestly, the fact that the U.S. pulled back from WHO at this moment is probably one of the reasons why the pandemic treaty resolution got passed, because if we'd been at the table, it probably hadn't been. So, we should not be sitting around during this moment and thinking that things cannot or will not move forward, right? So both of those things can be true at the same time. UN at 80. Right? Yeah. And at a time where certainly the U.S. relationship is fraught, the funding is fraught. But let's be honest, it's not just the U.S. funding that is fraught with it. We've seen a pullback, perhaps started by the U.S., with a lot of the funding across the world, right? But the U.S. has been such a big part of that funding, of course. It is causing an acceleration, I think, of the review of UN at 80, who should we be for UN 2.0, right? So, and in reality, yes, that is a question that should not just be posed, but should have been being addressed for a while. And maybe it's just being addressed much more urgently now. And I'm not sure where the outcome's going to get. I would say the United Nations is a special entity, more special, I think, than most people who don't work in the global area or with the UN realize, because we sort of take it for granted, all of us under 80, right? but the idea of a body of member states, because it's member states, it's not member cities, it's not member individuals, it is member states, right? So the power of governance coming together routinely over issues is sort of a big deal. But we are in a changed world even without this most recent U.S. pullback from the multilateral and multilateral funding space. You know, you study this all the time. We are in a multipolar, increasingly multipolar world, and not just a multipolar world, but multipolarities that shift and change over different topics.
Yeah.
You know, they're not fixed, not just regional or something like that, but different coalitions and different combinations of countries and powers on different issues. So what could or should a United Nations look like to better not just represent, but serve and make the most of that multipolarity in ways that still bring us together? It's going to be different. So, you know, money is causing some very quick changes. We might not only be in New York and Geneva anymore, right? That's probably not a bad thing, right? Yeah. But I think the real proof in the pudding will be what comes out of it. Is it just a scaled down version of the same roles, the same functions, the same benefits, the same costs? Or is it a chance to sort of reformat those priorities, those structures to better serve the world that's evolving? Of course, I hope it's the latter, but I don't know exactly what that looks like yet.
Yeah, one of the reasons why this podcast is called Worldviews is this idea that, well, we don't lack fora where leaders of nation states express their views and stances, and then you kind of sit at this standstill between different perspectives and you leave. There isn't much forum for deliberation debate, right? Not in the sense of like deliberation within a democratic assembly, but at least democratically between different cultural constituents around the world. Can we reformulate the UN apparatus in a way that allows for this kind of space where we exchange worldviews with each other in the way that we talked about how to make knowledge more accessible and more participatory, more inclusive, and more healthily contested, right? Do you think it's possible to also go a step further and deeper in terms of reconciling different knowledges or different epistemologies? Health scientists probably have an easier time doing that with each other.
I think we probably do.
Yeah. But then, of course, we have to face the non-scientific communities at home and then face the fault lines we have, right, between political communities. Can we learn something from the medical experts like you? Like, how can we debate more effectively and rather than hide our differences, turn that into something actually advantageous for us?
Gosh, I probably won't give you the answer that would be helpful on that one. I think it's a great question. I think another thing that makes the health collaboration very different, and I would not say it's been perfected at all, but easier than some of these bigger issues, is that in general, everybody who participates in the health debate, or most people that find themselves participating in the health debates over time, actually bring to the table a shared value that saving of life and health matters. So that outcome value is shared. And that is actually a fairly unique quality of controversy, debate, this and that other thing. And I wouldn't say that everybody is always showing up in good faith, but more often than not, they are. I would pose back to you, to what extent do we think a collection of nations shares the reason for having a collection of nations? I guess that feels like I'm undercutting the mission of the UN, and I don't intend that, you know, and its goals of, you know, peace, prosperity, health, a better world. I think those are good goals, right? But I think when push comes to shove, the reason for member states to be at the table is certainly much more complex than that. And the outcome they want to see, I'm not sure how often the solution, you know, the outcome is shared before we're debating the how to get there.
Exactly.
Yeah.
Exactly. Well, this skepticism, I think, very healthy one, right? It gets to the core of this question. We bring different historical memories
Yeah.
and different geostrategic
Yeah.
goals into the discussion in the first place. And of course, although we all agree on peace, preservation, peace, prosperity as the outcome that we all want, there are different ontologies and epistemologies and paths and methods that we take for granted going into those discussions, right?
Yeah.
How do you reconcile different normativities? How do you reconcile between different philosophical understandings of the end of human society and human life, right? That those are very deep questions. But maybe health can help us get there one step at a time, because flourishing biopolitically, right? That, since Plato, Aristotle, Confucius, I mean, every philosophical world has prioritized the health of individuals and the health of the polis.
Yeah.
So how do we build healthier societies? How do we build, and starting with healthy individuals, right? As a way of showing that this is a healthy community, and they feed back and forth. And maybe over time we can have healthy polities and forming a healthy collective of polities. That is for the long future, and we'll have to see what we can do in the here and now. But thank you so much, Shannon.
Yeah.
This is a wonderful discussion. And thank you so much for being with us, our audience. As you can see, we compared worldviews on public health, and we also compared worldviews from the perspectives, right, of public health. So I think it's doubly productive, right, because public health can motivate us to think about those philosophical differences in a grounded way, but it's also a way that feels so intimate to all of us. So thank you so much for being with us, Shannon.
Thank you for having me.
Thank you.
Great.